Welcome and thank you for joining us today for the intersectionality of obesity, cancer, and health disparities in population-based research. My name is Mabinti Conte, and I will be your WebEx technical support host. Before we dive into today's meeting, I wanted to provide some quick information on the webinar platform. All lines have been muted on entry and will remain muted for the duration of the webinar. Please submit your questions throughout the presentation using the chat or Q&A box and select all panelists. A moderator will ask your questions and/or comments on your behalf at the end of the presentation. If you require technical assistance, please feel free to contact Jenny Tweston via the host via the chat panel, and she'd be happy to assist you. Closed captioning is available and a link has been provided in the chat box. We also wanted to make you aware that today's webinar is being recorded. Also, as I'm sharing my screen, make sure you move your mouse away from the viewing application so that it does not block our wonderful slides our presenters have made for you today. And now I'd like to turn it over to Dr. Agnes Collins.
Good afternoon, everyone. Thank you for joining us for this webinar, the last final webinar series, as it explores the intersection between obesity, cancer, and health disparities. So we know that obesity is a risk factor for over 13 different types of cancers. Obesity and the health consequences of obesity disproportionately affects African Americans, Latino, as well as Native Americans populations, more so than any other race in the ethnic group. So at NCI, we developed 4 mini-series webinars that are focused on enhancing our understanding of the intersection of cancer, obesity, and health disparities in various populations. And so our series has focused on basic and translation research, clinical research, and today's webinar, we're focused on population-based research. From our session this afternoon, you will learn more about trends and disparities as it relates to obesity and cancer prevalences and mortality, specifically as it relates to breast cancer. Also, this webinar will focus on interventions to address causes of obesity and health disparities among medically vulnerable populations, specifically focusing on children and adults. I am delighted to introduce our moderator this afternoon, Dr. Amelie Ramirez. She is internationally recognized health disparity researcher at UT Health San Antonio, where she's the founding chair and professor of population health sciences and the director of the Institute for Health Promotion Research. She has over 30 years of experience conducting behavioral and communication research to reduce health disparities among US Latinos. Dr. Ramirez leads the Salute America, which is a communication program and national network of over 300 community-based leaders who drive healthy systems change for Latino health equity. Dr. Ramirez has received many recognitions. Just to highlight a few, in 2007, she was elected to the National Academy of Medicine, and in 2011, White House Champion of Change. We're delighted to have Dr. Ramirez, and I'd like to welcome her. Thank you.
Thank you so much, Dr. Agnes Collins, for this opportunity to be the discussant for this wonderful session and webinar that you and your colleagues at NCI have organized. I've been able to participate in some of the others and have just really learned so much information. I'd like to go to the next slide for just a moment, and I'm going to be giving you just a very brief overview or introduction to our session today. Our speakers are very interested in discussing with you the intersection of cancer, obesity, and disparities within our racially and ethnically diverse populations. We know on the next slide that cancer has just a number of contributing factors, such as genetics and the environment, viruses, substances such as tobacco, obesity, diet and inflammation, and the lack of physical activities. All of these things are major contributors to the development of cancer. And on the next slide, we find that these factors, we know that there is a link between obesity and cancer risk. The research shows that excess body fat and inflammation increases our risk for colorectal, breast, uterine, esophageal, kidney, and pancreatic cancers due to the excessive visceral fat that's affecting how our body manages our hormones and processes. And what we know today is that people who are overweight or obese are up to 2 times as likely as normal weight individuals to develop liver cancer, esophageal cancer, gastric cancers, to just name a few. And on the next slide, our racial and ethnic populations are disproportionately impacted by obesity. We find that nearly 48% of Black adults are obese. And in the Latino community, over 60% of our population is either overweight or obese. And obesity rates continue to be significantly higher for our children between the ages of 10 and 17. For example, among Latino children, we see about a 21% rate of obesity, and among our Black children, a 23%, and among white children, about 12%. And again, those are between the ages of 10 and 17. And 1 out of 5 children of color are already obese. We're going to lose a generation of our children if we don't do something to impact obesity. Early onset of obesity is a risk factor for morbidity and mortality later in life, not only impacting cancer, but we know as well as cardiovascular disease, diabetes, and a number of other health problems. Studies have shown, and you'll be hearing more from our speakers today, that women of color are also impacted with obesity, and that there's a significant association of obesity with breast cancer. Obesity is also strongly associated with an increase of prostate cancer among Black males. And on the next slide, I just want it to be a little provocative here in our thinking. As we see, there's many reasons that we're seeing these higher rates of obesity in our communities of color. For example, in the Latino community, we see that our community is facing a number of inequities, from poverty to the lack of social support, to access to affordable housing and transit and just care in general. And all of this is contributing to higher rates of obesity, not only for Latinos, but many of our communities of color. And also our communities have less access to neighborhood parks, playgrounds, so there's less ability to participate in physical activity, and also having more difficulty in accessing healthy foods because they may live in areas with food deserts. We still don't know the exact mechanism behind this trend, and so therefore we really need to learn more about the intersections of all of these 3 areas that contribute to obesity, cancer, and other chronic diseases. And as you'll hear from some of our participants today, encouraging individuals to participate in cancer studies or clinical trials related to obesity reduction is very important. And so they're going to share with you some innovative approaches that they've taken. But we know that this is just kind of the tip of the iceberg in looking at obesity and cancer. And we really need to work together to find more solutions. So now I'd like to introduce you to our panelists who have some wonderful expertise in this area. And we'll hold all our questions until the end. But our first speaker this afternoon will be Dr. Tiffany Carson. She is an assistant professor in the Division of Preventive Medicine in the Department of Medicine at UAB School of Medicine. She's also an associate scientist at UAB's Nutrition Obesity Research Center and the Comprehensive Cancer Center, and also with the Minority Health and Health Disparities Research Center. Her expertise is in the area of psychosocial factors related to obesity, such as stress, social support, body image, and quality of life. She has published in the areas of obesity, diet and physical activity, stress, and other psychosocial factors related to obesity in Black women. So let's welcome Dr. Tiffany Carson. Dr. Carson?
Hi, Dr. Ramirez. Thank you so much for that introduction. I really appreciate it. As a minor point of clarification, as the other slide displayed, I'm actually currently now at Moffitt Cancer Center after a recent job relocation, but a lot of the work and what I'll talk about today did happen during my time at UAB. So in addition to thanking you for that introduction, I also want to thank Dr. Eggers-Collins and the NCI for the invitation and for hosting this important webinar series on obesity, cancer, and health disparities. Today, I will discuss this topic in the context of African American women. And so I'll start by discussing obesity as a risk factor for cancer, and then briefly move into a review of the epidemiology of obesity and highlighting disparities in obesity and cancer. Then I'll spend a little time really exploring several interventions that are behavioral interventions in nature and meant to promote weight loss, and also talk about a little bit about what we might learn in terms of cancer risk, cancer prevention, and cancer control really across the cancer continuum. And then I'll conclude with just a few thoughts that I have in terms of challenges in this area and future directions for consideration. So as we heard in our introduction, obesity really is now accepted as an established risk factor for at least 13 different cancer types. The cancer sites are shown in this NCI infographic to the left side of your screen. Obesity is also associated with higher mortality for some cancers as well. So estimates suggest that about 3.6% of all cancer cases are attributable to high BMI. And we also believe that the percentage of cases attributed to overweight or obesity vary widely, really, for different cancer types. For example, there's a pretty robust literature in terms of breast cancer. And there was a review paper published by Bandera et al. Back in 2015 that really reported that measures of body size like obesity, weight gain, and central adiposity in adulthood were all associated with increased postmenopausal breast cancer risk. Even with these findings, there's still a lot to understand here because this isn't a simple relationship. There are multiple measures of body size and elements of energetics that really need further exploration. Data also suggests that there may be some racial ethnic variation in terms of these relationships. So for example, among Black women, central adiposity appears to have a stronger impact on breast cancer risk for BMI. However, among Hispanic women, associations with body size are similar to what's observed among white women. And then among Asian women, associations between body size and breast cancer appear to be stronger than what is observed among white women. Another important consideration in this relationship is cancer tumor subtype, as well as thinking about how that might relate to hormone receptor status. For example, with obesity or high BMI, there is increased risk for triple negative breast cancer, which is more commonly observed among African American women. So as cancer researchers, obesity as a cancer risk factor just really demands our attention because obesity is a global public health challenge. We see from this map from the World Health Organization that obesity prevalence varies by geographic location, with the darker colors really representing areas with the highest prevalence of obesity. Here in the US, the prevalence of obesity is currently estimated to be about 42% and is projected to approach 50% by the end of this decade. There are also implications related to health disparities, given that the prevalence of obesity is really disproportionately high among some demographic subgroups, and we'll look at that in the next slide. So we have this figure here that really illustrates the age-adjusted obesity prevalence among US adults by sex, race, and ethnicity. And from this slide, we see that pretty much across all groups, women tend to have a higher prevalence of obesity compared to men. And among Black women, that prevalence is higher than any other subgroup, here at around 55%. And then when we look at cancer and cancer incidence rates, particularly in cancers that are associated with obesity, we also see racial disparities. So this figure presents several of the obesity-associated cancers shown before. They are listed on the left with age-adjusted incidence per 100,000 shown here. The gray colored bars on the top represent white women, with the blue bars representing Black women. And as you can see, for nearly all of the cancers, with the exception of ovarian, breast, and thyroid, Black women trend towards having a higher incidence. And so here's another slide. The layout is similar to the previous slide, except this one actually looks at cancer death rates. And we see that Black women have higher cancer death rates in each cancer type as well, other than ovarian cancer. And I also sort of highlighted here just this striking difference in terms of cancer death within breast cancer. If you remember the previous slide, Black women had a slightly lower incidence of breast cancer compared to white women, but here we see that mortality is much higher. So taken together, these data really suggest that approaches are needed to help Black women with obesity to adopt behaviors that are associated both with healthier weights and with lower cancer risk. So things such as modification of diet and increasing physical activity. And one common approach for this is the behavioral weight loss intervention. And so here's where I'll shift gears and I'll quickly introduce several behavioral weight loss interventions that are sort of considered to be gold standard and look at outcomes related to weight loss. And I'll give you a little teaser that these previous interventions have shown some promise, but as you might suspect, there are some differences in outcomes that we'll look at. And then we'll also talk about what we can look forward to in terms of learning from these interventions as it relates to cancer risk and prevention. So I'll start with the Diabetes Prevention Program, which was a randomized controlled trial to examine the effects of lifestyle modification and metformin on the incidence of type 2 diabetes. Obesity researchers in particular became very interested in the intensive lifestyle intervention arm because it led to clinically significant weight loss and reduced risk for type 2 diabetes in a way that was, comparable to what was even achieved with the pharmacotherapy or metformin. And so the intervention included a 16-session core curriculum that was delivered to individuals over 6 months, followed by 6 months of monthly sessions, and really focused on achieving healthy weight loss through increased physical activity and fat and calorie reduction. DPP employed behavioral strategies like self-monitoring, goal setting, problem solving, and relapse prevention. And the intervention saw about 7% of baseline weight loss on average. But interestingly, secondary analyses were conducted and reported in a paper by Delia Smith-West and colleagues back in 2012. And this analysis revealed differences in weight loss across demographic groups. And so what we saw, as you can see from this figure, at 6 months, Black women lost about 4.9% of baseline weight compared to nearly 8% among white women for reasons that are not fully understood. So this is sort of that first indication that not only are there disparities in obesity prevalence, but there are also disparities in weight loss success among those attempting weight loss. Another interesting thing about DPP is that there is now an ongoing outcome study and there are plans for a cancer risk analysis. Some of the data around metformin has already been released and analyses related to the effects of the lifestyle intervention on cancer risk is pending. And so hopefully there will be something for us to learn there. And so next I'll move to the Look Ahead trial, which is another of the gold standard behavioral weight loss interventions adapted from DPP and was delivered in a group setting. It was designed to compare lifestyle modification to diabetes education among individuals with type 2 diabetes and really designed to examine the effects on weight loss and cardiovascular outcomes. And so while it was similar to DPP, Look Ahead also had a slightly higher weight loss goal, provided structured meal plans and meal replacement. Again, in Look Ahead, the intensive lifestyle intervention arm did experience significant weight loss, about 8.6% overall. And again, West and colleagues did an analysis by race, ethnic, and sex groups. As you can see, again, there was some variability, although in this analysis, the differences observed were not statistically different. But I will note that Black women trended towards having the least amount of weight loss across the subgroups, with Black women being represented with the darker blue line sort of at the top, and not to be confused with the one at the bottom, which represents white men. So with Look Ahead, this trial also is now looking at longer-term outcomes. The Look Ahead trial has looked at cancer outcomes in a secondary analysis of over 4,800 participants. There's about 11 years of follow-up included in this analysis. And From this 11 years of follow-up, data indicated that the lifestyle intervention was associated with about a 16% relative reduction in obesity-related cancers. Now, this comparison wasn't statistically significant, potentially due to not being powered to test this, but the trend of that magnitude and that direction definitely warrants further exploration. These findings really just give us some of the first evidence that the effects of obesity on cancer risk may indeed be reversible. And so now I'll move on to another study. This is really exciting, the Be Well study, the breast cancer weight loss study. And for those who heard last week's webinar, we actually had the pleasure of hearing Dr. Ligable, the Be Well PI, talk about the study herself. So I won't go into great detail, but the webinar is posted. I'll quickly give just a review that this is a multi-site randomized controlled trial to test whether women with overweight or obesity in a weight loss program after breast cancer diagnosis will have a lower rate of recurrence compared to those who do not get the weight loss intervention. And so to date, the study enrolled over 3,000 participants who were women with early stage breast cancer. There's a goal of up to 10 years of follow-up data, and the primary objectives for this study are invasive disease-free survival. And then there are also several other relevant secondary objectives that we can definitely learn from this trial. And then lastly, I'll move over and tell you a little bit about a project that I was involved in as a co-investigator during my time at UAB. So this study was led by Dr. Monica Baskin and was implemented to promote weight loss among African-American cancer survivors in the Deep South. This was a 3-arm cluster randomized trial where communities were randomly assigned to receive either a standard behavioral weight loss program delivered by trained lay health educators, that same program plus support for community strategies to promote weight loss, or just general cancer prevention education. Now, this study leveraged several of the same components of DPP and Look Ahead for the core intervention, but the really innovative elements also incorporated the lay health educators as well as support for community strategies. And I note these because this may be particularly relevant for the underserved populations that we really need to reach to address health disparities. So this study included African American survivors of breast, colon, and prostate cancer and a family member to serve as a support person. And the primary outcome for this study is weight loss. Analysis for this study are currently ongoing, and so we also look forward to having informative findings to share with you from this work as well. So as I prepare to close, I do want to raise attention to several key questions that I think we should think about in order to advance this work. First, how can we improve weight loss outcomes among Black women? Our moderator, Dr. Ramirez, mentioned several sort of social and environmental factors that may need to be considered. In some of our previous work, we've also discussed sort of innovative ways to reach underserved and diverse populations. Additional consideration and work is needed to improve outcomes, not only as it relates to obesity, but obesity-associated diseases like cancer. Another important question is how much weight loss is actually required to lower cancer risk? Is there a need to move someone from obese to non-obese? Is there a clinical sort of percentage that leads to meaningful risk reduction? We do have some early data among women who are 50 and older that was published in JNCI in late 2019, suggesting that there may be sort of a dose-response relationship in terms of weight loss and risk reduction, but additional work is certainly needed there across diverse populations. We also need to explore which anthropometric measures matter. As I mentioned, there seems to be variation in terms of if BMI, weight overall, waist to hip ratio, waist circumference may be a better predictor or risk marker for cancer. So we can further explore that in future research. Questions also remain in terms of variation based on hormone receptor status. And also just in general, how can we study the impact of weight loss on cancer risk given the induction period of cancer? So I think these are all questions that we need to think about in terms of the intersection of obesity and cancer and how we can really learn more about ways to reduce risk for cancer through modification of weight among individuals. So to summarize and really recap, I hope that we can leave this brief presentation understanding that obesity is now accepted as an established risk factor for several cancers. This is of particular importance when we talk about Black women who experience a disproportionate burden of obesity and associated cancers. And even, in the past year, as we see the intersection of obesity and cancer create sort of the ultimate risk profile for other conditions such as COVID-19 and having increased risk for poor outcomes among that population. While, there is still a lot of work needed for full understanding, we do have hope. Early evidence does suggest that weight loss may reduce risk for obesity-associated cancer, but much more research is really just needed to understand how to help Black women achieve healthier weights. And we also need more work to truly understand the link between weight loss and lowering cancer risk. So I thank you for your attention.
Thank you very much, Dr. Carson. Excellent presentation, and you raised some really great questions there at the end. I encourage people to put your questions into the chat or the Q&A so that we can be ready to ask at the end of our three presenters. Our next presenter is Dr. Andrea Richardson. Dr. Richardson is a policy researcher at RAND Corporation and a professor at Pardee RAND Graduate School. Her research focuses on nutrition epidemiology and encompasses the social and biological risk factors that underlie obesity throughout the life course. She is particularly motivated to address neighborhood investment or disinvestment, social injustice, racial inequity, and the impact of health in racial and ethnic minority populations. Dr. Richardson, thank you for being with us this afternoon.
Thank you, Dr. Ramirez, for the introduction, and thank you to my colleagues for the opportunity to be here. I'm really delighted to be able to share with you all some preliminary findings of our study, where we examine child obesity in relation to food insecurity and a possible protective role for school nutrition policy. So despite possible plateaus, child obesity rates are still high. And this really sets the stage for obesity, and not just obesity, but severe obesity in adulthood. Low-income children are disproportionately burdened. Based on national data, almost 1 in 5 low-income children were obese. And low-income children are also at increased risk of living in households that are food insecure, which is defined by limited access to adequate food. And at the same time, increasing research is showing that there's a link between food insecurity and obesity through the overabundance of unhealthy foods that are typically less expensive and more easily accessible than healthier items. Also, chronic bouts of deprivation can increase the risk of excessive consumption when foods do become available. Back in 1946, the school meal program was initially started by the Department of Defense as a means of national security to prevent food insecurity and nutritional deficiencies. However, in recent decades, as child obesity rates climbed, there was concern that the school meal program was actually contributing to childhood obesity by offering energy-dense and nutrient-poor foods and beverages. So in response to these concerns, the Healthy Hunger-Free Kids Act, or HHFKA, was implemented in 2012 as a means to reduce childhood obesity by increasing the nutritional standards of school meals. Under this act, the Community Eligibility Provision, or CEP, was introduced in 2014 as a means to increase access, and it began with some pilot years in 2011. Schools who participate in CEP are able to offer free meals to all of their students without any sort of paperwork or applications. Schools are eligible if they serve low-income students where there's 40% or more of the students are identified as low income. And since the national rollout, there's been steady increase in adoption, but there are still schools that are eligible that don't participate. For example, in school year 2016-2017, there were 45% of eligible schools that still did not participate. So the objective of our analysis was to evaluate whether CEP improved child body mass trajectories by reducing food insecurity. We used data from the Early Childhood Longitudinal Study, or ECHLS 2011, which followed students from kindergarten through 5th grade beginning in fall 2010. It includes 970 public and private schools across the country, mostly public. It consists of over 18,000 children with measured heights and weights. Parents completed the validated food security module, and for this study, we defined food insecurity by very low or low food security. In this study, we're also using restricted use data from the National Center of Education Statistics, the school identifier and school name. The CEP data from the pilot years were available from state nutrition directors. And then after the national rollout in 2014, the Center on Budget and Policy Priorities reports CEP participation. We linked these data to our ECHLS cohort by school name using the NCES identifier and the Common Core of data. So for our body mass index outcomes, we do not use percentiles or Z-scores because of their limitations capturing growth for children with very high BMI. Instead, per CDC recommendations, we use measures that are relative to the 95th percentile. We use body mass index distance from the obesity cutoff, which is based on age and sex-specific 95th percentiles. And then to classify weight categories, we use the BMI percent of the 95th percentile with these cutoffs. We use structural equation modeling, which is a pathway-based approach that allows us to test multiple equations simultaneously. It also provides fit statistics that tell us how well our model fit the data. Excuse me. And in this model, we're also able to include a latent variable that captures time invariant child characteristics. We're able to test whether the data fit a fixed, random, or hybrid model best. And we're also able to include lagged outcomes to account for the fact that BMI tracks over time within children. We controlled for a rich set of covariates that include birth weight, mother characteristics, as well as school characteristics. So our sample is based on public schools that were ever eligible for CEP during the study period. This gives us about 7,900 children. We excluded children who were never in poverty and never food insecure. We also excluded a group of children who were in poverty at all years because these children were almost all participating in the free and reduced lunch program. So CEP didn't necessarily increase their access to meals. This leaves us with an analytic sample of about 4,200 children. So this is a racially ethnically diverse sample of children, with the largest category being Hispanic at 35%. They're also living in relatively low income households. About half of the mothers report educational attainment of high school or less. So on the left is a plot of the BMID measures at the mean at each of the grades. And the red line that you see here is the zero referent which reflects the 95th percentile or obesity cutoff. So on the left, you can see at kindergarten, the children were on average about 2 BMI units below the obesity cutoff. By 5th grade, it seems to decline slightly, but you'll also see that the variability really increases. And this largely reflects the skewed distribution of BMI for children. So as you can see on the right, this is a BMI growth chart. And you can tell that during this window, when we're capturing the ages of these children growing from 5 to about 11 years old, the bands really widen over time. So we use this outcome and this modeling approach because in our prior work, we were able to identify an obesogenic association between lunch participation and prior to HHFKA. And this did not manifest, though, until 5th grade. So this suggests that there's an age-dependent effect of the school lunch participation on BMI that occurred before HHFKA. Notably, this obesogenic association went away after the policy was implemented. So when we look at our students by weight status, we see that by 5th grade, obesity and severe obesity increased. By 5th grade, 19% of the children were obese and 10% were severely obese. So this means that almost 30% of this group of children were obese or more by 5th grade. Food insecurity improved between kindergarten and 5th grade, and CEP participation was very low, of course, during the pilot years, but there was quite a jump after the national rollout. However, in this sample, it's still pretty low, not even reaching 15% by 5th grade. So now when we break it out and look at free reduced lunch price participation and food insecurity, we can see among the schools that were not in CEP on the left, about 75 to 80% of children were participating in the lunch program in 4th and 5th grade. Compared to, on the right side, we see that almost all children were participating in the free and reduced lunch program. Now, when we look at those children who were living in food insecure homes, we can see that there's slightly more children in the non-CEP schools who were in the lunch program and still food insecure. It is concerning that in the non-CEP schools, we also see that there were food insecure children who were not participating in the free and reduced lunch program. In contrast, in the CEP schools, any child who was food insecure was participating in the free and reduced lunch program. So this is a plot of BMID by food insecurity and CEP. And you can see that there's a lot of variability at 4th and 5th grade, so it's a bit hard to discern a pattern. However, the blue dash line at the bottom are the non-CEP students who are food secure, and they seem to have the best BMI trajectory. So this figure illustrates our model findings. So the rectangles that you're seeing reflect our variables of interest, and the arrows are reflecting the associations. So we have BMID at kindergarten up at the top left, and the arrow leading to BMID1 on the right is the BMID at 1st grade. And then flowing down to the bottom of the screen is the BMID at 5th grade. On the left are CEP variables at 4th and 5th grade, and then the rectangles in the middle are food insecurity, which are our mediators. So you can see the strongest associations were really the BMI tracking over time. These are very highly significant autoregressive coefficients. We did not see any statistical associations between food insecurity and BMID, but I will note that at 4th grade and 5th grade, the betas were increasing in magnitude, and in fact, the association at 5th grade was approaching marginal significance. We did not see any significant associations between CEP and BMID, either directly or indirectly through food insecurity. So our study has some limitations. We were not able to capture dietary behaviors nor physical activity, which are the most proximal drivers of BMI. We also don't know about the school meal quality or how much of the meals were eaten by the children. We know that even after HHFKA was implemented, school meal quality varies tremendously from place to place. Despite these limitations, we were able to capitalize on longitudinal data for children and schools. We used a flexible modeling approach that allowed us to track for BMI over time. And we used an outcome that accurately captures change for children with high BMI. So to wrap up, we did this study because obesity prevalence is still too high for children, and especially for low-income children. And it's unknown whether CEP might have improved food insecurity and child body mass trajectories. So we evaluated whether CEP improved body mass growth at critical ages in early life through reduced food insecurity. We found that obesity and severe obesity increased by 5th grade, and we found suggestive results that food insecurity may increase obesity in 5th grade. But the role of CEP is not clear. We still have a lot of work to do. So we really want to think more deeply about our exclusion and eligibility criteria to make sure we're capturing the correct counterfactual. We also want to explore subgroup analyses by race, ethnicity, and sex. And then to account for any possible selection bias between kids who are in CEP versus those who are not, we want to use weighting methods to balance the two groups. And then I'm excited that we have a supplement where we will be able to incorporate national data to examine how CEP may have buffered against food insecurity during COVID-19. So I'd like to thank our funder and my team. And I'll thank you, and I look forward to any questions.
Thank you very much, Dr. Richardson. That was very interesting presentations, and questions are coming in. So please continue adding your questions here so we can have a lively discussion after our third presenter, which is going to be Dr. Gary Bennett. Dr. Bennett is a Bishop McDermott Family Professor of Psychology and Neuroscience in Global Health and Medicine at Duke University. He's also the director of the Duke Global Digital Health Science Center. His expertise and interest are in the integrating digital health and treatments into primary care settings, and he's created a research program that designs, tests, and disseminates digital obesity treatments. So welcome, Dr. Bennett.
All right, well, apologies for that overly dramatic introduction. I am Gary Bennett, and it's my great pleasure to be joining all of you this afternoon. My very best to all of you and your families as we continue to navigate this pandemic. I thought I would start out by contrasting a bit the challenge that we've had in treating the obesity epidemic, which for me was the pandemic that we were dealing with before the current pandemic. And, I think if we look at our existing treatment guidelines for obesity, you see them here. And my thanks to Dr. Carson, who did a wonderful job earlier of laying out the evidence base for our existing treatment guidelines. Indeed, we've had a series of very important gold standard randomized controlled trials that have resulted in guidelines like these, which fundamentally can be reduced to the recommendation that we eat less, move more, and that we essentially go through a structured program, a behavioral weight loss program that's guided by an interventionist. These are in general, our sort of our best guess, our best guidelines, I should say, as to how to contend with the obesity epidemic from a treatment perspective. The problem, though, and as Dr. Carson very nicely laid out, is that we've had persistent disparities in nearly all of our gold standard behavioral weight loss trials, including the diabetes prevention program that she so nicely laid out earlier. But this really extends to many of the other types of treatments, behavioral weight loss treatments that are largely derivative from the DPP and the look ahead, the power trials, the early trials. In the last generation of behavioral weight loss interventions, one thing you can say with some consistency is that we rather frequently see smaller weight loss outcomes for populations that have the highest prevalence of obesity, underrepresented populations, folks of color, those in socioeconomically disadvantaged groups. And the weight losses that we observe are consistently less clinically meaningful. This is a major challenge for us. It's a major clinical gap, and it's been extant really as long as we've been doing this work. I think about this most frequently in the primary care setting, where we have an additional set of challenges, which is that go ask your doctor is a pretty good recommendation for just about every clinical condition except for obesity. These days, if you only about 20% of our patients with obesity receive counseling in the primary care setting for good and understandable reasons. Clinicians have told us for many years now, time barriers, reimbursement challenges, efficacy challenges, training challenges really get in the way of their ability to effectively intervene on obesity in the primary care setting. But one of the key challenges is that those patients who are the least likely to receive counseling are those with the highest prevalence of the condition. From my perspective, you can sort of summarize the challenge facing medically vulnerable populations. And again, I define these as folks who are in underrepresented groups, those who are socioeconomically disadvantaged, those in rural settings. In my work, which I'll describe in a little bit, we really see all three of those groups co-occurring. The challenge is that these groups are more likely to have obesity. They're more likely to have the chronic diseases that travel along with obesity. They're a driver disproportionately of the healthcare costs that are really plaguing our health system. They are less likely to receive treatment, particularly in the primary care setting. And when treated, they consistently demonstrate less success. This for me is a clinical gap that portends very serious consequences for our ability to manage conditions like cancer, given, as was described earlier, that rather sizable connection between obesity and a range of cancer outcomes. And so we've been interested in how you think about this. But before I get to that, I want to remind us again about these guidelines. And I'd ask you to imagine a scenario in the modern health system where you would encounter any treatment that has the type of intensity that you see described here. There aren't that many things that we do in the healthcare system that involve all this. And if you sort of take a layer back, if you sort of ask yourself a slightly different question, which is, what do these guidelines really require of patients, providers, and the system? It sort of boils down, in my view, to this. We're really asking for very highly trained providers in most cases. I was happy to see Dr. Carson mention the work she's doing with lay health providers. I think that's an important area for us. It requires patients who have significant discretionary time. I can tell you the patients that I work with would receive pretty significant sanctions at their jobs for taking the hour off each week to participate in behavioral weight control intervention if fully disseminated in their healthcare system. Nearly every one of our trials has required, either by design or the sort of design of the trial itself or the design of the intervention, high weight loss motivation, which we know is actually not that common in the general population. We have high expectations of literacy and numeracy. Limited comorbidities are something we find quite frequently in trials unless we're explicitly designing the trial for that purpose. And this costs a lot. These kinds of treatments are expensive, and we haven't had a lot of success reducing the costs to a level that allow them to be disseminated fully into the modern health system. So we've been interested in this question. How do you think about the next generation of behavioral weight loss interventions, particularly for medically vulnerable populations? And we've been leveraging digital. I could spend the next couple of hours, assuming I don't have technical difficulties, talking to you about the evidence about what works in digital therapeutics or in digital health treatments. But I hope that you will just stick with me and stipulate to these things. We find engagement is one of the most consistent predictors of outcomes for obesity, digital obesity treatments, but also digital treatments for a range of conditions. One of the most fundamental contradictions in the digital health space is that the vast majority of our evidence, particularly in obesity and physical activity and some emotional health outcomes, really comes from digital treatments that are combined with human counselors. Or to put this another way, we have very little data that standalone digital treatments, like those that most people download, actually produce durable weight loss outcomes. Most of the academic evidence really points to interventions that combine digital with human supports of some type. There's a lot to say about devices. I'll mention this in a little bit. But really, I think if we can try to limit the literacy and numeracy requirements, which it's totally possible with digital treatments, there's good evidence that we get stronger outcomes there as well. And so we've developed a digital treatment approach that we call IOTA. We've been testing this for just over 15 years now in a variety of trials. I'm going to talk very quickly about two of them, but I thought I would just give you some insight into what we do. here, essentially what IOTA does is that we ask participants to fill out short surveys, and then we use algorithms to personalize a series of very common sense, very easy to understand behavior change goals to our patients. Those goals are driven by some of the psychosocial characteristics you saw on the previous slide. And then we ask people to go off and self-monitor them. Self-monitoring being one of the most crucial drivers of success in behavioral weight loss interventions in general, particularly for digital. And what digital allows us to do is to make that self-monitoring easier and also to really deliver highly personalized feedback. You see an overly busy slide here, which describes one of the ways in which we provide feedback through text messaging or interactive voice response, or even a voice agent like an Amazon Echo. And you can see here that what we do is that we piece together this personalized feedback using different goal libraries and I should say different feedback libraries, different algorithms. And when we put it all together, it has the feeling of having a personalized experience. We often will use devices in the trial. I'm going to talk to you, the next two trials I'm going to tell you about. We use devices, we use network connected scales based on work from my colleague Dory Steinberg and others showing that this kind of approach can lead to weight loss outcomes independently, particularly when we compare it with personalized feedback. Again, the importance of support cannot be overestimated. And again, if we're delivering these kinds of treatments in the primary care setting, our best evidence are for digital approaches that help the human counselors to do a better job, more efficient job at their core task, which is helping to promote accountability, helping patients to deal with setbacks and the like. And so we often, almost all of our trials are pragmatic in design. All of our trials use human interventionists that are employees of the health systems where we conduct this work. And so the trials I'll be talking to you about now involve counseling delivered by registered dietitians who would otherwise be providing WIC services in these health systems. One of the things that's really nice in the digital therapeutic space is that we can leverage the data in creative ways. Our registered dietitians like to see all of the data, as much data as we possibly can give them. And so you see an example of one of those interfaces here. However, when we're delivering data to our care providers, they really want just the facts. And so we can summarize the data that are coming from patients, that are coming from interactions with registered dietitians, and deliver that to our physicians through the electronic health record in ways that allow them really just to read this very kind of simple counseling snippet to their patients and deliver the kind of dose that we think they can do well. And so I thought I would just talk very quickly about two studies. One of them is called TRAP, which was a 2-year weight loss intervention in the primary care setting. This was in federally qualified community health centers in North Carolina. Again, we used as interventionists physicians who are employed at the health care system, but also registered dietitians who also were employed there. They have a really nice electronic health record, which we were able to leverage for this trial. Both the studies I'll talk about were conducted in close collaboration with Piedmont Health Services, this system of federally codified community health centers here in North Carolina. And they look like most community health centers do, serving the working poor and in our state, uninsured largely, broad cross-section of individuals. This trial was designed to target patients who had obesity and one of 3 comorbidities. They either had to have hypertension, diabetes, or have dysregulated lipids. And you see that this group looks like most of the patients we encounter in the community health center context. Generally, the working poor, predominantly folks of color, predominantly women. This was I should say, it was a pragmatic trial, and the one that I'll talk about in a second was even more so. High rates of smoking. 21% of our patients had all 3 of the eligibility comorbidities. All of our trials, between 20 and 25% of our patients have depression. That's a score in excess of 10 on PHQ-9. And so I won't bury the lead here. Over the period of a year, the kind of intervention that I just described to you, that would be monthly calls with one of the registered dietitians, at least weekly use of one of our apps, over the period of a year produces about 4.5 kilos at 6 months, which drops a bit to about 4 kilos at 12 months. This amount of weight loss is is about what we see in gold standard primary care-based weight loss interventions. These are data from my colleague Larry Apple, who's at Hopkins, who I think has the seminal behavioral weight loss trial in the primary care system. And you can see in his study, Power Trials, at 12 months, they also got about 4 kilos of weight loss with an intervention that was a little bit involved a more heavier kind of a intervention design and with fewer digital components than we observed. We think this is notable because generally speaking, as I mentioned earlier, we tend to find much smaller weight loss outcomes among medically vulnerable populations in trials like these. So we think this compares pretty favorably. But if you ask yourself, are folks in these populations going to use these apps? The answer is yes. If we ask the question of, if we sort of define our expected rate of app utilization as once per week over the course of a year, we do very well there from an engagement perspective. And what's important about engagement, and I think it's actually the most important thing in the digital health space, is that when you look at patients who are highly engaged, here, these are folks who use the app more than 80% of the trial weeks, we see significantly greater weight losses, significantly greater improvements in a range of secondary outcomes. And we see this really quite across the board. This is about a third of the patient population here who have engagement in excess of 80% of the trial weeks. What I want to note here is that we've been resistant over the years to involving clinicians in the design of these trials just because they have so much going on, but we won't do that anymore. They have a very important effect. At the end of this trial, we asked patients to tell us whether their clinicians had counseled them on weight loss. And if the clinician mentioned general diet advice, we saw no additional weight loss. If the clinician mentioned general exercise advice, no additional weight loss. If the clinician mentioned the kind of counseling snippet that we asked them to note to their patients in their clinical encounters, really if they told their patients, look, it's a great job, you're doing a great job with this track intervention, I want you to keep it up, they lost an additional almost 4.5 kilos at follow-up. And we think this is a really important effect. Now, I'll note that we talk a lot about weight loss in the obesity space and the behavior and the treatment of obesity, but I think it's very important that we really think about comprehensive obesity care, which comprises both weight loss but also weight gain prevention. It's about 50 to 60% of patients with obesity are not ready for weight loss for one reason or another at any one time. These are data that come from NHANES, and the lack of interest or lack of readiness in weight loss is more common among those patients who have the highest prevalence of obesity in the first place. So we really need solutions. I call them second line solutions. Obviously a first line clinical treatment is to proceed with weight loss, but if that's not possible, then our next best clinical option is to prevent weight gain. This is particularly true for women, given in the premenopausal years, given the rate of weight gain that we traditionally see. And so we used this kind of IOTA intervention that I described before. And with IOTA, we're able to tune down the energy deficit that we create with the assignment of behavioral goals that patients are self-monitoring. So here we did that, and we found that over 18 months of follow-up, the red line, the intervention group, really that we prevented weight gain. This was not a weight loss intervention. We recruited patients who were not interested in weight loss, but you start to see that rate of weight gain in the blue group in our control arm, which generally, depending on the study, is between 1 to 3 kilos per year. This was all in Black women who were premenopausal and had either overweight or up to stage 1 obesity. But the important point here is that, again, these are people who are not interested in weight loss, but if they actually use the intervention at a high level, they were highly engaged. Again, we define this as using our app more than 80% of our trial weeks. They actually lost a little bit of weight, which we think was a good thing. We came back 4 years later and did a chart review of patients who were enrolled in this trial. And what you find is that over that 4-year period of time, patients who were enrolled in this intervention actually stopped gaining weight. You see that expected rate of weight gain in the control group, but we see this prevention of weight gain effect in the intervention group. We've now taken this intervention and we're testing it in the entire health system, including men, women of all races and ethnicities and languages. and with a completely different design where we're trying to decrease the cost of this intervention and make it something that's light enough to be employed in regular clinical care. That's a pragmatic trial that's currently underway. This approach of using these digital therapeutics in medically vulnerable population, we've shown in 4 or 5 RCTs in this setting to do a wide variety of things. I've noted earlier the pretty consistent finding of depression in this patient population, which is not actually related to weight. So we generally do see a reduction in weight and depression secondary to weight loss. In this population, that is not generally found, but we do see reductions in depression, which we think of as being related to kind of a behavioral activation kind of an impact that comes along with the kinds of digital treatments that we're prescribing. So this kind of approach, it can work. Using these digital treatments works in medically vulnerable populations, and I think we need more work of this type in order to close that clinical gap that's been so pressing for so long. So in summary, I would say, particularly for cancer prevention, we need to think about comprehensive obesity care solutions, both weight loss for patients who are ready or motivated. Prevention of weight gain is an important second line offering. Using our technologies is critically important, but what I've come to learn as a frustrated programmer is that technologies help humans to deliver their care at a higher level. And so really finding ways of combining, of sort of carefully integrating digital approaches alongside human supports, I think gives us the best opportunity for clinical impact. And I'll note here that, I used to believe that digital therapeutics were one way of reaching medically vulnerable populations. These days, I think it's one of the best ways to reach some of these populations, particularly in busy care settings that would be otherwise unable or unmotivated to address challenging behavioral conditions like obesity. So with that, I'll thank you for your time and look forward to answering any questions.
Thank you very much, Dr. Bennett. Very enlightening. All our 3 speakers have been phenomenal, and we've got some questions coming into the chat, so please continue to have them come in. My first question will be for Dr. Carson. From Dr. Song, would you elaborate more on the association of obesity with triple-negative breast cancer? And also, I was wondering if the association differs by race and ethnicity or due to menopause status.
So what we do know from the epidemiologic data is that individuals with triple-negative breast cancer, typically there's a higher prevalence of obese individuals with triple-negative breast cancer, and there are some physiologic mechanisms to sort of indicate that relationship. In terms of differences by race ethnicity, we know that Black women tend to present with triple-negative breast cancer at a higher rate than white women, and triple-negative breast cancer tends to be more aggressive. They present with a more advanced tumor and typically end up with poor outcomes. So, and just linking those 3 things together, understanding that weight control may be a way to lower risk for triple-negative breast cancer is something that we should sort of take under consideration.
Okay. Thank you. Thank you very much. A question for Dr. Richardson from Rapa Mahadeva. What were the increased nutritional changes for the school lunch program? The free school lunch programs that are available in Louisiana mostly offer sweet cereal for breakfast and pizza and hot dogs for lunch. So curious as to what were the measures being taken to improve the nutritional profile of the school lunch program?
Yes, the standards included increasing fruit and vegetable servings as well as whole grains within the grains that were being offered. They also limited milks to fat-free milks. But like I mentioned before, implementation of these nutritional standards is tremendously varied. And it also depends on the vendors that are available. And whoever the schools are working with. I will say, if there's pizza in a school, it still has to meet the nutritional standards. So it still has to have the appropriate amount of whole grains.
Good. Thank you, Dr. Richardson. A question for Dr. Bennett. Could you please, and this is from Maral, could you please give some insight as to how to motivate people to stay engaged with their digital applications as well as getting them interested in weight loss?
Well, if I wish if I had a great answer for that question, I promise you, I'd probably be sitting on a beach somewhere right now. But I'll tell you that I think that the from an engagement perspective, we find that it's really about the feedback. So one of the things I didn't mention is that we spend a lot of time thinking about how to deliver personalized feedback that will motivate patients to track the next time. So we use a 1-to-1 ratio between any kind of tracking and the provision of feedback. The other way to say that is every time we get data from a patient, we provide her some feedback of some type. And we think about constructing that feedback in ways that will be motivationally enhancing. So we may give them some interpretation of their kind of weight changes to date or their behavioral changes to date. We deliver a kind of supportive message. We think about how to reinforce the kinds of positive changes, and again, to provide some support for areas in which they've been having some difficulty. But this is really the place where I think humans do the best job. It's where the accountability hit that comes from a really qualified clinician who's informed by good data can provide, it can be very, very helpful in the context of ongoing care. I know, I have to tell you, my experience hasn't been as helpful on how to motivate interest in weight loss in general for patients who are unmotivated to do that. I will say, however, that on the back end of most of our weight gain prevention trials, we do find that many patients are interested in going on to and continuing that work. They have some small changes that they have found motivating in and of themselves, and we're really interested in that effect and trying to figure out how to optimize on that.
Thank you. Thank you very much, Dr. Bennett. This is a question for the panel, and it's from Aubrey Villalobos. So anybody chime in who would like to respond to this? Can the panelists talk more about addressing the upstream factors that are leading to obesity, including structural racism, and how researchers should think about intervening there?
I'll chime in first, if that's all right. Thanks. I think that's an excellent question, and I think there are a myriad of upstream drivers, and systemic racism is at the root of a lot of them. And I think research is starting to broaden into these realms, getting past just access to food and physical activity resources, and really trying to understand where people are and how policies and practices have changed and created inequities in where we live and how we live. So I think that is a great question, and I'll interested to hear from my fellow panelists.
So I would echo that I think it's a great question, and that we are starting to move and think about things in that way. In some ways, some of the unfortunate events that we've all experienced over the past year, I think, has opened the conversation for us to think about structural racism, structural inequities, as it has, perpetuated disparate outcomes in COVID and other spaces, but that applies in so many other areas of health, including obesity. I think another important thing that is being elevated more, and I think we should consider, is that, race is not the risk factor. Race is the social construct that is associated with, other variables that are the risk factor, one of which is obviously racism associated with race. So I think, in thinking about our research that way, these are some things that we should perhaps measure, and that will give us more data in terms of where we might intervene. Some of my work personally looks at the role of stress and stress management in Black women, and some of that is driven by racism and discrimination, and the role that may play in weight loss attempts and weight management efforts as well. So I think it's spot on, and it's not only things that we can do at the individual level, but also at the system level as well.
Thank you.
I think beautifully said, Tiffany, and I completely concur. And I think a lot of the movement in the obesity world towards thinking about policy solutions, I think, may help us in this regard. Ultimately, many of these, fully upstream, systemically racist drivers of the more downstream challenges are best managed with, I think, with policy interventions. I will say, though, that one of my hesitations about this, though, or I should say, it's a bit of a caution, is we have 100 million Americans who have obesity right now. And even if tomorrow we were to, effectuate policy solutions that would reduce the sort of anti-racist challenges that are facing the racist challenges, racist issues that are facing our country, we would not necessarily see a reduction in the weight of that 100 million people. And in fact, we know from the few studies that have looked at the remediation of food deserts that we don't immediately see changes in the waistlines of the folks in the affected community. And so I think we have to do both, and we'd be remiss to imagine that we should move beyond the sort of behavioral weight loss work and to fully focus on policy solutions as our kind of primary way of dealing with the obesity epidemic. We have to do both.
And Gary, I hope you don't mind if I start calling you all my first names here. One of the things that I was very interested in your presentation was the importance of depression amongst many of our patients. And I see it a lot in other types of patients who are depressed, have been diagnosed with breast cancer, and when we offer them alternatives to different types of programs that would help improve their health, there's still that, how should we phrase it, kind of an inability or hesitation to move forward. And so I'd be interested, again, from the panel's perspective, how do we deal with this? Because as you said, of the 100 million that are being impacted by obesity, we know there's a level of depression that's going on there. And how can we really help our communities, our individuals, to move forward and doing something positive for their health?
It's such an important question, and I can tell you that it is one of the biggest challenges that we experience in our trials is that we have a sizable proportion of all of the patients who are in all of our trials who have undiagnosed depression. What's more challenging is that the vast majority of those have never received any type of treatment whatsoever for their depressive symptoms or for clinical depression, and are unlikely to receive that treatment. That it's a real challenge for us, particularly here in North Carolina and in the more rural circumstances in which we work. So I have been surprised that the kinds of interventions that we deliver for these other kind of clinical targets have these spillover benefits for emotional well-being. Perhaps I shouldn't be surprised by that, but I have been. I will note that one of the things that's been more surprising to me is that our clinical partners are more interested in these interventions from a dissemination perspective because of their impact on emotional outcomes than they are about the obesity outcomes. That's the thing that has really gotten their attention. And they've been asking us the question, what else does it do? What are these kind of other impacts that it might have among the patient populations? They really see that as a key dissemination target. So I'm hopeful. I hope that we as a community of scientists can think about ways to get beyond our kind of hyper focus on single outcomes and really think about the wide ranges of impacts that some of our interventions may be having. I suspect they have larger, more broad impacts than we sometimes study. And moreover, I suspect that at least in our experience, that might be one of the really important keys to effective implementation.
Great, thank you. Tiffany or Andrea, any comments?
No, I think he answered it beautifully.
Okay, great. All right, thank you. Well, we have more questions coming in from our audience here. There's one for Tiffany from Danielle. Are you familiar if there are any data on long-term changes in physical activity among cancer patients and whether these changes are different by race or ethnicity?
Yeah, so that's another good question. I'm most familiar with a couple of cohorts among breast cancer survivors and physical activity among those populations. And in general, what they have all sort of consistently reported is that, the vast majority of survivors overall are not meeting the minimal guidelines for physical activity for breast cancer survivors. Most of the time, it's around a third overall. And then for the work that has looked at this by race, ethnicity, typically we see that Black women are even less likely than white women among those to actually achieve those minimum guidelines. So again, generally, most are not meeting the guidelines overall, and then there is some variation within race as well.
Thank you. And a question for Andrea. Let's see. Have you done, or do you know of anyone who has done any qualitative work to learn how the CEP is implemented? This question was from May Wang.
Yes, so as I mentioned, CEP adoption is very variable across the United States, although it has increased steadily since it was rolled out. The reasons why some schools participate and some don't have to do with reimbursement. There's a certain range of the proportion of students who are identified as low income, that is 40 to 62.5%. Those schools will not be reimbursed completely for their meals that they are offering. So there's concerns about reimbursement. There's also concerns about losing other programming, such as Title I. So the FRAC is a group who have been doing a lot of work to understand barriers to CEP implementation and working with schools and school nutrition associations to understand these reasons and how it is being implemented in different locations.
Great, thank you. And Gary, a question from you from Larkin Strong. How do you handle challenges associated with low technology literacy among participants?
So I'm glad you asked that question that way, because the challenge of low technology literacy is the challenge for the developers, not for the patient. And so you might have seen in some of the images that I showed, might have seen examples of text messaging. I think the first answer to this question is that you use modalities that don't require heavy use of graphical interfaces. So we use text messaging, interactive voice response, we use vocal user agents, things of that ilk first before we design apps, more smartphone apps. Because they're easier for our patients to use, and they are the kinds of things that, one of the things that people sometimes find surprising is that, if given a choice of what kind of technology modality to use, the thing that works best in our experience across a wide range of age groups and populations is actually interactive voice response, the kind of automated telephone calls that we love to get from our banks. Those kinds of things work extraordinarily well in sort of digital health applications, as does text messaging. So limiting the kind of interface challenges, focusing on very, very face valid, very clear answers. So we work very hard to make it easier for our patients to use, say, text messaging. And so one of the ways that we do that is that instead of asking patients to, say, self-monitor the amount of food that they ate or the precise food that they ate, we ask dichotomous questions. Have you achieved your goal of doing X? Or how have you, were you able to do Y? So that we can limit the amount of technical challenges and limit the literacy and numeracy challenges that our patients may have. That means that the nerdy, quantitatively inclined scientists that are doing the work are sometimes a little bit less satisfied with the data that we're getting, but I think it works better for our patients, and that for me is a reasonable exchange.
Thank you. Now a question for our panel again. This is from Neil King. Any comments on the role of bariatric surgery as a means for addressing obesity?
So I may just jump in first, and then I'll, let Gary and Andrea also chime in with their expertise. But I would say that, from what we know from research, bariatric surgery is one tool in our arsenal to treat obesity. Obesity has multiple different origins and multiple different levels of severity. So, as a biobehavioral researcher, I am certainly a proponent of, behavioral interventions for obesity, pharmacotherapy when needed, bariatric surgery when needed, as well as combinations of those approaches.
Thank you. Anybody else willing to chime in?
Sure. I'll just say briefly, I couldn't agree more. There's a time when I was a little bit more concerned about bariatric surgery approaches, and I'm much less concerned given the more recent data, including with some newer approaches like ESG. I think these can be extraordinarily important tools in the arsenal, for those of us who care about obesity care. What I am more concerned about in that space is the challenge that we're having with patients not being as successful as they might like with the aftercare regimens that often accompany bariatric surgery. This is an area where those of us in the behavioral treatment space, I think, have a lot to add, and where I hope increasingly that our physician colleagues recognize that, because the sort of growth of secondary surgeries in the bariatric space, I think, is quite concerning and likely not always clinically necessary if we do a good job helping our patients manage some of the behavioral and motivational challenges associated with those procedures.
Yeah, I'll also add that I completely agree with my colleagues. Bariatric surgery is a very effective tool, but it is an invasive surgery and there are risks. And just like, Dr. Bennett mentioned that there's risk of weight regain and failure. And so it's much, from my point of view, my motivation is to prevent the weight gain to begin with.
Thank you. And oftentimes with bariatric surgery, if we're not dealing with the root cause of why the individual got there, there are rebounds going on as well. So, okay, another question for the panel is, and this is from Conal Reddy, is obesity becoming a bigger problem since the rates of telework are at levels that we have never seen before, and are there any correlation?
It is my house. I don't know about yours. I think we just got some data maybe yesterday, earlier this week, suggesting slight weight gains over the course of the pandemic. I'd be shocked if we don't see a dozen studies suggesting the same on the backside of this. I don't think there's any question about that. There have been some smaller studies of employed populations that engage in telework, and they've been, I think, less conclusive than I might like, but I think a lot of that is confounded by the age group of the folks who have traditionally done that kind of telework. It'll be a different scenario for us moving forward if we see more employers shifting towards a kind of work from home scenario. I am as concerned about sitting as I am about diet in this regard. As concerned about the sort of challenges that we've seen, the creep between work and work-life balance, impacting sleep. There's a lot of things, I think, for those of us who care about behavioral conditions. There's a lot of considerations that I think we should be watching, in a lot of areas, I think, for new science in the years to come.
Anybody else going to contribute?
I was just going to say that I might add that, if we think about particularly over the past year with the shift to telework that we've seen, I'd be careful to just attribute it to that move to telework, right? So Gary started to touch on it, but there are a lot of other potential confounding things that may be happening during this time, increased stress levels, for some food insecurity, for others, constant access to food in the home all of the time, and some other restraint challenges. So, I suspect as well that there will be, a little bit of weight gain during this time that we can sort of detect. But I think the number of factors that contribute to that are probably more than just, this move to telework and less physical activity, more sedentary behavior.
And I will just add that I'm hopeful that there's a lot of lessons we can learn from this time, so that even if we shift to a more hybrid sort of work model of a lot more teleworking occurring, that maybe we can start to embrace some better work policies around getting people to integrate physical activity throughout their workday and allowing more flexibility in scheduling, perhaps.
Thank you. Thank you very much. This is a question from Tony Balamos Cruz, and this one's for you, Dr. Richardson. Is there a policy that asks schools to provide a minimum nutritional standard, or is it feasible to ask schools if there's a minimum nutrition standard to offer?
Yes, and in fact, based on recent research, most schools are able to meet the new nutritional standards. They've been out for a while. There was a lot of feedback from schools when they were first introduced or even proposed. But yes, schools are able to meet these standards. And in fact, a lot of the concerns that people raised about the act was that there would be increased plate waste, reduced meal participation. And a lot of these haven't come to pass. So a lot of the concerns have not materialized. Again, though, as I mentioned, schools do have a tremendous amount of balls up in the air for how they implement these nutritional standards and how they purchase meals and how they offer meals. So, across the country, there's a ton of variation. And, there's a ton of variation in terms of funding. So that's a huge role too.
I was going to say funding is critical, right? It's amazing what some schools do with $1 per child, and others that have more resources to offer. So,
exactly.
Thank you. Thank you. This is a question for Dr. Carson from John Shepard. My question has to do with study targets. Don't you think that we should get away from weight loss and state more fat loss? The benefit of weight loss is the loss of fat, not any losses in lean or muscle.
So I think it's a reasonable question, but that's also something that I hopefully sort of alluded to in the presentation, in that I think we need to think about multiple anthropometric measures as it relates to both obesity and cancer risk. A lot of the epidemiologic data that we have is literally based on weight or on BMI, because that's sort of what we can do in population-based studies. And we at least see some evidence there, that there are important outcomes and risks that are associated with weight and BMI. Obviously, body composition is important. And when, we can have measures of body composition in our studies, I certainly think that there's added value, and when we can target other body composition measures, there's added value as well. But I think that goes to my point that there are more areas to investigate. We talk about BMI versus weight change versus central adiposity, waist circumference, and associated risk with those different measures. So,
okay, thank you very much. And a question for Dr. Bennett from Lori Donzi. How much contact did the dietitians have with the patients using the Track app? And is your app available to the public or only to study participants?
A great question. So the study dietitians had monthly contact for about 20 minutes with the patients there, and they did it all via telephone. A side benefit of this treatment is, and I know you didn't ask this, Lori, but here goes, is that in these kind of settings, you see a high churn rate among registered dietitians who provide WIC care. They have about a year to 18 months in usually before they leave and move on. And what we have found as a side effect of participation in studies like this is that we prevent that churn. We haven't lost registered dietitians in these care settings. We think it's because the task switching really appeals to these clinical providers who want to do a range of clinical tasks. But it was about 20 minutes by telephone, very simple, very lightweight. Our apps are available. They are open source. They are not in the App Store. And if you're interested in them, please feel free to contact me.
Great. Well, I think this has just been an amazing discussion amongst all of us, and I can't thank you enough for our three panelists for making time to be with us this afternoon. Please continue to send in your questions. I think that the NCI organizers and Dr. Anders Collins will help us get responses from the panelists, and we can send those out to you. This afternoon, we've heard some amazing speakers discuss the intersection of obesity and cancer among our minority populations, and how food insecurity plays a role in childhood obesity, digital therapeutics for obesity in vulnerable populations. It's clear from these presentations that while the field is growing, more research is needed. We need to do more innovative research to reach our underrepresented populations. And as stated by our presenters, obesity affects almost half of the US population, and it starts at an early age. So we really need to think about what are some comprehensive policies that we need to begin to implement to address the causes of obesity, like food insecurity, or how we can boost nutritional programs such as SNAP and WIC for our low-income families, you know, to improving school meal nutrition. And also just how to get our young children to have better meals and better opportunities for exercising. So again, I want to thank very much Dr. Angus Collins for the invitation to be part of this amazing panel. And I'd like to take it back to you to close us out this afternoon.
Thank you so much, Amelie. I just want to thank the moderator, Amelie, as well as our speakers, Gary, who did an outstanding job, Tiffany did an outstanding job, as well as Andrea. So we really appreciate all your presentations. And I'd like to thank the audience for their participation as well and for your research questions that you submitted. And I'd like now to mention that we have a webinar for our next series. And that's going to happen on June the 3rd, and it's titled The Interface of Insulin Resistance, Chronic Inflammation, and Cancer Risk. So stay tuned for additional information and resources related to this series. So once again, I want to give a standing ovation to all of our speakers and moderators, and we thank you so much for joining us this afternoon.